So, how are we going to treat a patient? This is one of my favorite patients that I've ever treated. This fellow was sent to me, again, he had already been to a general dentist's office. He had already had full mouth scaling and root planing. His wife sent him to me after he'd already gone through all of that, and this is the picture of him after he'd already had scaling and root planing with his general dentist. His wife sent him to me because he had horrible bad breath. Okay? Now this guy is a dental fears patient. So he hadn't been to a dentist for 20-some years, and he's already been to a general dentist. He's already been through lots of shots and lots of scaling, and you can see he still has significant amount of localized inflammation and really bad breath. Well, this is what he looked like a year after I treated him. But I was only able to do the scale. I had to redo all the scaling and root planing because as I checked him when he came in, everywhere, it doesn't look like there's too much going on here, but everywhere you see that little inflammation, there's subgingival calculus, and it's burnished calculus. So the instrumentation that was done with dull instruments. It wasn't done thoroughly, and all they did was smooth off the calculus. And so the nidus for that inflammation was still there. He also still he'd never been put on any kind of mouthwash or anything, so he still had lots of bacteria that were stuck in his tongue and tonsils and so forth, contributing to his bad breath. So this is what he looked like. We made a real believer out of him on home care. He did extraordinarily well. We were able to do full mouth scaling and root planing again. He still had some residual pockets in the back, which we've talked about as, sort of the norm. For most patients, you can do a lot in the anterior part of their mouth non-surgically, but lots of times you have to still do surgery in the back. So I did the surgery on this side. You can tell that this is the side I did the surgery on because I also took off all these big bumps that he had of exostoses back here. So this looks a lot better, doesn't it? This side ended up not having surgery. Guess what? His mouth was so sensitive after I got through with him that he couldn't go like that without, jumping off the ceiling. So we ended up having to very aggressively treat him for his root sensitivity. So we put him on chlorhexidine mouth rinse twice a day for almost that entire year. We did some other local therapies for his root sensitivity. But the interesting thing is that after a year on recall and him doing a wonderful job of oral hygiene at home, he ended up not having to have surgery on the other side, which of course made him very happy because those areas healed in the presence of meticulous home care and frequent recall. Now, could we have expected that recession? So let's go back for a second. Could we have expected the recession that we got? Well, you see how much inflammation there is here. And you see that he got probably at least a good millimeter, maybe close to 1.5 millimeters of recession when we got rid of that infection, right? And is that about what you would expect? The answer is yes, it is. So, in the studies, if you have shallow pockets and you instrument them aggressively, you're going to lose attachment. You're going to have about 1/3 of a millimeter on average recession. If you have medium-sized pockets, you're going to reduce the probing depth by over 1 millimeter, but you're also going to have a good 0.5 millimeter recession. In the deeper pockets, which is what he had in the front there, you're going to get 2 millimeters of probing depth reduction, but you're also going to get at least 1 millimeter of recession. And that's exactly what he had. Now, so the bottom line is that, again, as I mentioned earlier, you need to tell the patients they're going to have recession. They may have sensitivity. Fortunately, for most patients, the sensitivity only lasts for, several weeks. And you can usually control it with a chlorhexidine mouth rinse and perhaps a prescription sodium chloride high-level dentifrice. Now, so this is what you can kind of naturally accept. So let's think about that a minute. If he had 7-millimeter pockets, I told you we ended up not having to do surgery on the other side. Well, he had some areas where he still had like a 6 that bled here and there on the other side. Well, once we got him all cleaned up, if he was the normal person in those 6-millimeter pockets, if he got 1.5 millimeters almost of attachment of probing depth reduction, and he gained a little bit of attachment, and he got almost 1 millimeter recession. So now all of a sudden, you got something that's more like a 5 or 4.5 that doesn't bleed. So can you live with that? Yeah, you can. So, not all deep pockets are going to respond this nicely, but a lot of them will. And so sometimes you just need to do a really, really, really good job of debriding those pockets and giving the patient really intense oral hygiene instruction, frequent recall, and give him all the tools that he needs to really do a good job of cleaning his mouth. And let him heal. And you'll be amazed sometimes. And I'll show you some pictures in a little bit where we can even get radiographic bone fill in some of these cases. So, what I've been describing has been studied in the literature. I've been doing this technique with the ultrasonic for 30 years. In fact, that case I just showed you, I treated in 1982. Okay? So I'm telling you, I've been doing this a long time, and if you do the debridement meticulously, and you keep that patient on good oral hygiene, and you keep them on maintenance, you will be amazed at how many patients that you can keep very healthy for a long period of time. So this full mouth disinfection is what I've been describing, has been studied since then. You see, this is a 2010 study, and what they added to what I've been doing is in Europe they have the opportunity to have a 1% chlorhexidine gel, and so they've added that to the routine so that they've been able to use chlorhexidine as the antimicrobial. So they've scrubbed their tongue, they've had them rinse with it, and then they've irrigated the pocket with this chlorhexidine gel. And the idea again is to get those bugs out of there, okay? And if you look at their data, you can see that 61% of the sites were reduced by 1.5 to 2.5 millimeters. Well, 40% of the moderate sites and 27% of the deep sites didn't even have any pathogens at 6 months that they could detect. So it's been shown that you truly can disinfect that pocket and get some pretty significant clinical results. Now, I've been talking about this this video I'm going to show you, and again, this is from University of Louisville, and again, this was recorded, believe it or not, almost 20 years ago, but it's still the very actual thing that I do in my practice. This happens to be an ultrasonic that was produced in Europe that I've used for many years. And in this case, in this particular one, they have titanium tips that are a little bit bigger and stronger. This particular case is a 35-year-old male, and this is in Kentucky now, who smoked 4 packs of cigarettes a day. I'm not kidding you. 4 packs of cigarettes a day. And you can see that he has, significant staining, but he also has a ring of black calculus around every tooth. I'm going to kind of fast forward this a little bit. Now, what I'm going to show you is, and you can see the purple hue underneath there. There's a solid ring of calculus around every tooth. He's never had his teeth cleaned. Never. You can see this. It looks almost purple underneath there. All right, now, and I apologize if I pop off the tooth a little bit once in a while because I'm making this by looking in a monitor instead of the patient's mouth so I can keep my head out of the way of the camera, okay? But this tip is 14 millimeter. This is a 14 millimeter tip I'm using here. This has povidone iodine, as I mentioned, 3 parts of water to 1 part povidone iodine. You can see I'm going up into these. This is an advanced periodontitis case. This guy has 8 to 10 millimeter pockets all up in here. He has heavy calculus. These are class 2 mobility, class 2 furcations. And you can see that I'm going clear to the base of the pocket. I'm burying that 14 millimeter probe almost, or tip of the instrument. And I'm working from the bottom of the pocket up. Now, obviously, he is anesthetized, but I'm doing 2 things with the tip, and it's hard for you to maybe see that as I'm working. But not only, this is real time, so I'm going to do this man's whole mouth, half a mouth in one day and the other half the next because he's so bad. But as you can see, I'm going around each tooth, going to the base of the pocket, and I'm coming forward. And after I have instrumented the root surface, I'm then putting pressure with that ultrasonic against the soft tissue. And if you had loops on like I had on when I was doing this procedure, what you could see is that the skin is just sort of rolling out from that pocket. In other words, I'm not only getting the calculus off, you can begin to see the little flecks of calculus fly out of there, but I'm also putting pressure after I've gotten the tooth clean against the soft tissue. So I'm doing a curettage actually with the tip of that ultrasonic. Okay, does that make sense? And in a second here, let me just kind of fast forward this just a little bit. And in a second, you'll see that after I finish with the ultrasonic, sometimes the tissue, in his case, he's had a lot of chronic inflammation. You see this space? See that space around that tooth? See, I haven't gotten the calculus off on this side, but see this space? That's where I've curated out that nasty infected tissue in the pocket. Now I'm going back around with an EXD 1112 Explorer, and I'm carefully checking all these root surfaces to make sure they're clean. Now you see this little papilla is beginning to sort of wobble a little bit. Sometimes in this one in a minute you'll see it's almost disconnected from the other side. See, I found a little piece of calculus there. See it? So I'm going to go back in a minute and I'm going to hand scale that area and then finish again with the ultrasonic. You see how this papilla is beginning to kind of come loose? And that will frequently happen when you're doing this really aggressive ultrasonic bactericidal debridement. Okay, now here I am. Now look where I'm fulcruming. I'm fulcruming right on that tooth. Now watch this. Now, you see the calculus coming out? You see this guy's head moving? This is not a gentle procedure, okay? But you see all that nasty epithelium that I'm pulling out of there and the calculus? You see that head moving? You see how I'm fulcrumed? I mean, my nickname in high school was Muscles, so you got the picture here, right? So then you go back and get all those places that you saw that had residual calculus, and then you go back through and re-instrument with the ultrasonic again, and I'll go fast forward again. So go back through, make sure everything's clean, and I'll go forward a little bit more. Now, I'm finishing with ultrasonic, which is what I mentioned earlier, because I want to make sure I don't leave a bunch of tags of tissue in there, a bunch of disconnected calculus, and I also want to flush that out with the iodine again. Now, this little papilla right here and this one are pretty much flopping loose now. So now you're going to have to make a decision before you let this patient go home, and then we're just going to stop that right there. So you're going to have to make a decision before you let that patient go home. You're going to have to either coap the pillow with a wet sponge and hold it for 2-3 minutes, and then put some periodontal pack over it to keep that stable until it reheals. Or you have to put a suture in, one or the other. You can't just leave it flopping, okay? Now, so that's my technique, and I've been doing that for a long time, and there are lots of data now to show that a really thorough debridement and the right patients can be very effective. Now, they've come up with some new names for what I've been doing for a long time, and some of the studies now that have just been done and published, this is a 2011 study, they've called it now minimally invasive non-surgical approaches, okay? And basically what they have found is, and they've called the non-surgical minced and the surgical mist, nice catchy names, but basically it's the technique I just showed you. But let me show you a couple of things out of the publication, because I think it speaks well that other people have been able to do this technique and have had really good results. This is in a closed environment now. No, just like I showed you, no incisions, minimally invasive non-surgical therapy. And you can see this is in this particular case, it's out of the article. This is you can see the calculus right there. See that? And you can see this big vertical defect. So you go up in there, you get all that cleaned out. See that residual calculus? That's what you got to get out of there. And then, look at this. Look at that healing within a few months. That's without a flap. That's without an incision. That's just getting the stuff off the teeth that the gums don't like, okay? And this would be the minimally invasive surgical piece. So this is a big vertical defect, big circumferential defect between this these two incisors, a little papillar reflection, not very much, but enough to where you can get in there, clean up the defect, and again, look at the healing. So this is just what they call a mini flap, a minimally invasive surgical therapy. But look at this defect on this radiograph, and then look at it here. And so you've done that with very little recession. There's been a little recession, but this was pretty inflamed to begin with. But, you know, very little recession on the adjacent teeth. So that's sort of what people want now. They don't want to be, you know, leave your office with big, long horse teeth, okay? They really want to see a difference. This is another example of the minimally invasive. One little suture. There's the defect prior to this debridement. There's the defect debrided. One little suture. This was prior to the surgery. This is a 15 millimeter probe, so this is like a 12 millimeter defect. This is that same 15 millimeter probe, and now we're at 4. Not bad. Not bad. And see what else has happened? Look at the x-rays. So this hasn't completely darkened yet because it hasn't had time to totally remineralize. But look what else has happened. See that space there? And look at this space. I don't think that's a problem with the x-ray. I think it's because, as you normally see, that when you get rid of the infection, the teeth will sometimes close back their diastemas. Because Mother Nature is such that she wants to get away from this infection, so teeth will drift. And then once you get the infection under control, they will go back to their normal place. You see that all the time. So, we talked about studies, and we do know that for sure that one of your ways to make sure you're successful is to make sure those patients keep coming back to see you. And if you don't, if they're erratic in their compliance with maintenance, you're going to have more bone loss, more tooth loss. And if they're diabetic and smoke, it's going to be even worse. So, how do you know when you're done? Well, you obviously know you're not done when you look at this picture, but there are some studies to show that you may actually have infection of the calculus. And remember I showed you my slides from 20 years ago? Well, now they've done some studies in the laboratory to show that there's, even in calculus, calcified plaque, that there can be viable bacteria, which is pretty cool, when you think about it. And that's partly why it's so important to get it all off. And I love this picture. This was taken by one of my residents years ago. And this was a patient who needed to have a tooth extracted. And so he took a little bit of the pocket with it because we were doing some research with this pocket material. But I love this because it's a very good picture of what calculus and plaque and that epithelium in that pocket do to each other. And this one is like a pocket turned inside out. And you can see how red it is and how inflamed it is where it's been in contact with this calculus. So, first of all, you shouldn't be probably taking out a tooth unless you're pretty sure that it's hopeless, because once you get all that stuff off the tooth, it's going to be amazing what it can do. This is one of my residents who didn't do such a good job of scaling. I could have killed this guy because look at this calculus he's left around here. Look at this. And he had already done a scaling and root petting on this patient. And he still had bleeding pockets. Well, guess what? Of course he had bleeding pockets because he still has all of this residual calculus. You can see where his instrument stopped, about 1.5 millimeters under the gum. So the gum's reflected back now, but the gum had been up here. So the guy did a really good job of getting the first millimeter clean, but he didn't even begin to get the rest of it clean, right? So if that's how you scale and root plane, then you're going to have to do a lot of surgery because you're not going to have good results. Now, I'm just going to touch for a second on antibiotics because antibiotics really don't have very much of a place in treating inflammatory periodontal disease. If you get all the stuff off there that you need to, then the only people that you really need to use antibiotics with, and that's on a very few, are really aggressive periodontitis cases, and perhaps a case like I showed you early in the talk of the woman who was the undiagnosed diabetic. If you have a diabetic or if you have aggressive periodontitis, the literature is pretty clear to show that you need that you can have some benefit from using a systemic antibiotic. And in the case, I'm not going to go into the whole antibiotic lecture right now, but there are times when you need it, and in particular, in this particular group of patients that I'll show you just quickly, is that this periodontist out in California, John Kwan, who is a terrific clinician, used antibiotics and along with this full mouth antimicrobial debridement that I mentioned to you earlier, and he routinely got results like this. And again, see, very deep pocket. You can see the calculus on the root, and look what else. You see the space between there? Remember I told you that the teeth have a tendency to go away from the thing? Look at this. Well, you can tell he's done some pretty hefty instrumentation here, but look what happened to the contact. Everything closed back up, and so did the pocket. So if you look again, look at that. This is non-surgical. But this did have some help with antibiotics because these were really aggressive periodontitis cases. So, we're not going to talk about the antibiotics right now, but maybe in another lecture we can talk about that a little bit more. But routinely, you don't need them. But if you do need them, you need to give them in the right prescription in the right number of days. Most people in today's world use a combination of amoxicillin and metronidazole because it attacks both kinds of bacteria that are very much a part of periodontitis. And this is just another case that I did many years ago, another non-surgical case, and you can see this woman had class 2 mobility. That's why these teeth are splinted. You can see this huge defect on her lateral, and this is what she looked like a year later. So in her case, we used systemic antibiotics at that time, which was amoxicillin, because way back then she had a mitral valve prolapse, and we had to use that to do her surgery, or no, I mean her scaling. And but you can see from the date, this is from 1985. So as I said, I've been doing this a long time, and it works. Does it work for every patient? No, but it works. Now, I'm going to just show you one last little bit of some new instrumentation that's being developed by some periodontists in this country. Steve Harrell, for one, and John Kwan, who I mentioned earlier. They have come up with some instrumentation that will help visualize the calculus under the gum. And let me just show you this one quick case. This was a lady who I saw who was referred herself to me because her teeth were drifting, and she'd already lost some lower teeth. She was only like in her 50s, and she'd been going to the same general dentist for 25 years. He had never cleaned her teeth. And he told her that he wasn't going to clean them because it would hurt her enamel. Well, we all know that that's not true. He's lucky she didn't sue him. Anyway, so about the time this lady came in, she had no money. She was scared to death of surgery, but she wanted me to fix her teeth. Okay. So I thought, okay, I have this new prototype of this instrument that I've been asked to try. And so I will treat you if you'll let me take lots of pictures and if we can try this new instrument. So she said yes. So you can see the lower lingual. I mean, this dentist had just made her a new partial denture on top of this. Can you imagine that? Really, really poor treatment. So you can see why this lady was scared. So I used this endoscope. This was a prototype of what was called an endoscope at the time, where you could slip this scope down into the pocket. It would magnify the tooth area 40 times, and it had a light that was shone down in their tooth. And so you could really take a good look at what was down there. Now, it wasn't very handy for trying to look while you were cleaning, so I would clean with the ultrasonic, and then I'd go back in and look with the scope. And this was what the prototype looked like. They're working on some new versions of that now. So you can see that if you were looking at the tooth in this slide, this part right here, this yellowy looking half circle part, is actually the back side of that scope pushing the gum tissue away. And then this frosty looking stuff here, this is the crown of the tooth, this is the root of the tooth, and this is some calculus. Of course, with this thing, and then this is the inflamed tissue. Remember I showed you that picture with the inflamed tissue next to the calculus? So this is the real thing. This is what it looks like when you look down in there. And this frosty looking stuff, I mean, it looks like a boulder, of course, when it's magnetized 40 times. So you get a really good look at what you're missing, because you can scale and scale and scale and scale, and you'll still see chunks of calculus down there. That's the reason most people just give up with non-surgery and do surgery. They flap the tissue back so they can see it, okay? But not all patients want that, and they won't let you do it. And so this was a perfect example. So the endoscope, you can look up implications, but this is basically what it looks like in the pocket. Now, this is what she looked like when we started. We did that full mouth debridement, like I mentioned. This is what she looked like just a couple weeks later. Huge difference. Look at this. Huge difference. And look at the lingual. Now, is she perfect yet? No. But there's a big difference between the pre-op and the post-op. Now, she still had really deep 6 millimeter or so. These were like 11 when we started. And part of that was because she had all these big epuli from that poor fitting partial. By the way, by the time we got this inflammation all down, the partial obviously had about a quarter inch of space between it and her tissue because it didn't fit any longer. The metal didn't fit. Anyway, she still had a bleeding and a lot of inflammation here. A lot of the other areas looked a whole lot better, but this one still didn't look so good. So I put that scope down there, and guess what I saw? Exactly 6 millimeters down on the mid-lingual is a big hunk of calculus I'd missed. It took me 20 minutes to get it off. But when she came back a year later, this is what she started with on that tooth. This is what we ended with. She has total, this is the little blood vessel here. She has total fill of this huge defect. Huge defect. Non-surgical therapy. We got the stuff off the root that the gums didn't like. Now, can you do that every time? No. But can you do it some? Absolutely. So you create an environment in which the body can heal. Now, does the literature back that up? Absolutely. There are papers out there. This was a classic set of papers from Cadell, who showed that most therapies are going to have some recession. The deeper sites are going to have more recession, and you're going to have the most recession with surgery versus a modified Widman surgery, this Aussie surgery, versus modified Widman versus scaling root plane. But at 7 years, they actually had better gain in clinical attachment with the non-surgery. So the scaling was better than the modified Widman was better than the surgery. So is that true for every site, every patient? No. But scaling and root planing maintains attachment levels. Okay? So basically, just to end, this is what we've been talking about. We've been talking about taking probing depths that are less than 4. You don't want to instrument them too much. You may get recession. Most people can do with just a nice scaling, and then you reevaluate them, and then you put them on recall. But if they have greater than 4 and it bleeds, you need to do the scaling. As I mentioned, I always follow up with chlorhexidine mouth rinses. Or you need to do the technique that I showed you with the ultrasonic and the debridement. And you may want to use that new endoscope. There's some out there in the market now, but they're still working on those. And so there won't be long, though, I think in another few years, that endoscopes will be affordable and people will be using them a lot. And then at reevaluation, so we talked about the reeval, so this is really important. At the reevaluation, then if you still have probing depths that bleed, then you may want to look at local drug delivery, systemic antibiotics, perhaps using some of those host modulation types of things. If they're not bleeding, then you just put them on recall, and you can use a regular dentifrice or some kind of irrigation, home irrigation. That's fine. So, in conclusion, I hope what I've helped you do today is to understand that non-surgical therapy, if done properly, can be very successful, particularly in shallow to moderate pockets, maybe not all the deep pockets, that most people use a combination of surgery and non-surgery, and that even if you have to do surgery, the non-surgical preparation of the tooth is extraordinarily important for your long-term results. So I thank you for your attention today, and I would be happy to have you contact me if you have any questions about this presentation. Thank you and have a great day.